Good day, my dear postgraduate students. We are meeting after a long break. The topic that I had taken for the day is technical and on gross discussion. Always I used to say, think of the subheadings. The subheadings will take you to the question or to the answer. And these are what we should be anticipating. Now, always when we think of pathology, there should be a background of normal anatomy. In this case, thanks to Reed Quinton for this particular picture. Wonderful. And a simple dissection of the colon along with the ileocecal junction. We are able to see the cecum over here, then a projecting appendix, the ascending colon, transverse, descending colon, sigmoid, and the rectum. Also are seen are the tags of fat with which we are able to identify. We are supposed to look for the tinea coli or the bands of muscle. Something that is of importance, which we do not see as pathologists, will be the lymph nodes and the sphincters. I would like you people to kindly frame your own questions. They might form 50% of the answers. As is your anatomy, so is your pathology. As is your pathology, so is your medicine. This is a sagittal section that is showing the bladder, the rectum, and pararectal fat and the spine. This is the tinea coli that I have been talking about, which is a band of muscle extending up to the rectum itself. There is a slight difference, we shall not bother about it. These are the various parts, kindly go through it. Also important will be an imaginary cross section where the same structures are being displayed beautifully. One thing that will be of paramount importance will be the lymphatic drainage. Now that this is a picture of the rectum mainly, what I would like to apprise you people is there are different groups of these lymph nodes. Look at the colors over here. These are the internal iliac nodes or the paramesonephric nodes over here. And there will be the internal iliac nodes also over here. And there will be the common iliac nodes. This we should be familiar with. So there are the mesonephric nodes, the internal and the common iliac group of nodes. Have this in mind. You need not be as perfect as Arjuna in a case of anatomy. The pathologist is not always a perfect butcher. What are the types of surgical specimens that we shall be getting? They can be polypectomy or a colectomy, which is again divided into a right hemicolectomy, a right extended hemicolectomy, left hemicolectomy, transverse, descending, and the sigmoid colectomies. Sometimes a total proctocolectomy is done. And this is done mainly in conditions such as familial polyposis. And please do remember, surgery and pathology go hand in hand. Actually, it will be important that we have some knowledge of the surgical procedures before landing in pathological trouble. Also, the resections can be as per the anterior resection for high rectal tumors, abdominoperineal resection, total mesorectal, intersphincter resection, extra levator resection, total proctocolectomy, and pelvic exenteration, which means removal of the contents from a body cavity. This will happen in a case of advanced tumor where there is adhesion and their mass has to be removed in blood. And this is a particular reference which I would like you people to kindly go through if time permits. A beautiful one which from Word I had prepared the PowerPoints. What are the types of specimens that we usually get? Generally we are asked, is it neoplastic or non-neoplastic? So it can be neoplastic, benign or malignant, vascular, inflammatory, congenital. All these come under non-neoplastic. Traumatic is another one. And we should also look for the lymph nodes, the resected margins, and if there has been any chemotherapy or radiotherapy given, what is its impact? And was gross examination will be essential in a case of inflammatory bowel diseases. This is again a classification which is an aid to orderly thinking thanks to my Professor of Dermatology, Dr. Augustine. The types of specimen can be histological block selection, specific lesions as such, colorectal cancer, polyposis, IBD, and in cases of occult bleeding, the site of suspicion. Again, it is a repetition of it. There can be a radical surgery, there can be a localized excision in the case of a superficial polyp, or in the case of a carcinoma, again, there is a radical excision. And what we are supposed to do with the polyp, the stalk, and the submucosa. This is somewhat controversial and shall be dealt with. Also, you people should know that it is a further indication of a surgery and this should be included in the report. A continuity of the surgery must be seen in the pathology report. Polyp is nothing but a lesion that protrudes above the surface. So there are different types of it. This is a beautiful black and white picture as such showing the glandular architecture and the underlying stalk. So this is a stalk over here, a normal epithelium, and then there is a polyp which can be pedunculated or it can be sessile sometimes. And there is a beautiful schematic picture of a villus adenome. The polyps itself, there are different procedures for grossing a polyp. What happens is, if this happens to be the superficial surface and multiple cross sections are being taken, this is against my school of thought. I used to take a clean longitudinal section through the stalk, but this is one. Through and through. Probably they want to rule out any kind of minute invasion of the lamina propria. Lower down, however, the infiltration into the muscularis becomes important and therefore multiple parallel sections are being cut. So kindly do understand this is another school of thought which we should be having in mind. And these are given over here. So polypectomy. What will be important is whether it is invading the lamina propria, but even then per se, it is not malignancy. It has to invade the muscularis layer, and so this can be designed as a dysplastic polyp. Whereas here the muscularis mucosa is being traversed and then it is being given a term as an adenocarcinoma, maybe an early adenocarcinoma. Endoscopist is another picture. So we will have to be in concordance with the endoscopist, the surgeon, the clinician, and the previous records of the patients. See what is seen over here. I am finding multiple projecting hemispherical masks. And this is a closer view of the same. And this is almost similar to this. And hence, can I describe this as a cobblestone appearance? And you people all know that a cobblestone appearance occurs in Crohn's disease. In fact, it happens to be multiple polyps, a familial polyposis. The sampling of multiple polyps will be, you will have to do the resections for both the neoplastic as well as the non-neoplastic. Invasive malignancy is uncommon when it is less than 1 centimeter, and progressively you find that there is an increase in the incidence of malignancy. Sufficient number of polyps will have to be sampled in a case of mixed polyposis syndromes. Normally, in any of the specimen of the colon or rectum, these are the parameters that should be followed. There has to be an adequate fixation and dissection, evaluation of the lymph nodes, resected margins should be examined and commented upon. What is the extent of the peritoneal covering and what happens to the cecum, etc. The ascending, descending, and the upper are retroperitoneal over here. The high rectum has a circumferential area without the cecum. This is somewhat important. I shall be showing it to you in a line diagram. So the identification of all the lesions will be important. However successful you are, there is no substitute for a close relationship. We all need them. What do we mean by this word? So, there are multiple organs as such, and they are in close relation. We will have to be thorough with them. There are 3 levels of examination of a polypectomy specimen. What is the size, the architecture, dysplasia, and the completeness of the excision. So, you all know, I'm not going to go into the detail of this. The adenoma can be a tubular adenoma, a villous adenoma, or tubulovillous adenoma, depending on the percentage. And each one should be more than 20% for its name to be included. For example, if the villus is 30%, it comes under tubulovillous adenoma. And the invasion, the muscularis mucosa has to be invaded. Otherwise, you give a diagnosis of a severe dysplasia. And when we examine a specimen of a colon, always have other things in mind. We will be asked, there can be a diverticular disease, Meckel's diverticulum whatsoever, inflammatory bowel disease, ischemic colitis, there can be partial gangrene, valvulus, angiodysplasia as possible, motility disorders, Hirschsprung's disease in the case of a child, radiation colitis, a toxic megacolon, again a complication of ulcerative colitis. The pathologist will have to know something about the underlying disease, its complications, and the cancerous lesions you can get. So non-neoplastic also, there are varieties of pathologies. Always we should keep our mind open to that. What we do is we get fresh unfixed specimens which are usually unopened or stable. There has to be a flushing of the contents of the colon, and the rest of it will have to be fixed in a closed manner with 10% formalin. Otherwise, if it is going to be delayed, it can be refrigerated at 4 degrees centigrade when it comes beyond 4 o'clock. This is to avoid autolysis, a common problem before holidays. And the rest of it will have to be put in 10 times the amount of the specimen, the fixative. The fixed specimens are used for routine diagnostic, immunohistochemistry, as well as molecular biology techniques, whereas unfixed can be used for electron microscopy and for research purposes. So this is what is happening. I told you earlier. Unopened specimen, you find that the serosa will have to be examined earlier. Look for any lesion such as a fistula or a perforation before you open it. And if at all you do open, it is opened along the antimesenteric border. We are using the antimesenteric border because along the mesentery, there will be the various drainage, the blood vessels, etc., which should not be tampered with. And after opening, it is pinned onto a corkboard and again left for fixation for a further period of 48 hours. It is a very delicate organ and it has been filled with microorganisms. Therefore, autolysis is very probable. Strictured specimens again washed and they are kept afloat. We are living in a world of perceptions. I would like you to decipher what is there in the picture. To be continued in the next class.